Thank you very much, Chair. As we are two people are presenting in this today, I'm called Katuramu Richard. I am a physician and at the same time an epidemiologist. I'm working at the National TB Literacy Program as the National Drug Resistance Coordinator. I'm also a former trainee and still a trainee of implementation science. Actually, I sponsored my training and I'm still part of the team. Thank you very much. My co-presenter will also talk about herself in this. So I'm going to talk about the introduction and dwell more of the study design, which she had also said, which is very important. Then Grace will talk about the findings from the study, and then we shall discuss the way forward. So we are looking at the health system barriers, implementation of TB preventive strategies in South African primary health care facilities. Clearly, we chose this study. One, it has implementation work in it, and two, it's also applicable towards now healthcare settings. So this is just an acknowledgement. As I said, personally also benefit from implementation science research and training, and also my presenters also under the same benefit like me. So just a brief background. Yes, TB is one of the most, actually it's one of the major public health concerns, causing about 10 million infections and about 1.4 million deaths worldwide. And one of the preventive strategies that has come up is TB preventive therapy. Sorry, here we're using IPT, but as more, I wouldn't delve more into the preventive therapies, but at least it's one of the preventions of TB. But here we shall be discussing IPT per se. And we know that there's a global plan to increase the uptake of TB preventive therapy by at least 90% among people living with HIV by 2025. South Africa, just like Uganda, is one of the 30 high TB burden countries. And actually, there's a very high TB burden in South Africa, with about 1% of South African population experiencing TB per year, and of which more than 60% are people living with HIV. And scaling up of TB preventive therapy among people living with HIV is one of the strategies that have been set up not only in South Africa, but in Uganda as well, and globally. But the problem was that IPT itself uptake was quite low, less than 10%, and in Uganda we're also still under the same percentage, the uptake is low. So what could be the problem? Previous studies which have done not only in South Africa but worldwide have shown that implementation of uptake of IPT had some barriers. For example, people didn't have knowledge and experience in terms of IPT itself per se, inaccuracy of TB screening tools to exclude active disease, fear of resistance of isoniazid, and also shortage of the drug itself, plus lack of clear guidance, which actually WHO changed the guidelines. So we may not proceed, we may not really take these guidelines in this paper, but what we're interested in is the implementation science, because the new guidelines were released. And during the introduction, because they had put on TST, plus stratifying it by art status, so this made logistical and human resource challenges in implementing these guidelines within the population of interest. So one of the things that we know that improving the implementation of evidence-based practices will involve behavior change, not only to patients, but also to care providers and also the health systems that we work in. And one of the best models that we use and all frameworks in implementation science is the COMBI model, which stands for capability. How are people capable of carrying out the behavior that you're interested to change? What are the opportunities that could be offered within the setting you're doing, and also what motivates the health workers or all the patients to be able to execute what you're interested in carrying out. So this model was used to identify the barriers for implementing IPT, and not only identifying but design an intervention so that they could be able to improve uptake of IPT in their country. Dwell on COMBI model. As I said, behavior is really part of a dynamic system that interacts with people, whether they are capable of doing it, are they motivated, and then do they have an opportunity, or I can say a chance, to be able to exercise what you're telling them to do. And any given moment, a behavior occurs when those three have to come into play. As long as those three don't come into play, then most likely you're going to fail in terms of behavior. You know the COMBI model. I think most of you posted in this room, you know the COMBI model in details. as it has three. COM stands, C stands for capability, O for opportunity, and M for motivation. And all of them interact together. As you look there, sorry, you can't get the cursor there, but as you look to interact between here the behavior and motivation, and you can see capability together with motivation with opportunities. So all of them have to interact in order to be able to make a change. But all of them, you can see, it could be physical, psychological in terms of people whether they're capable. Motivation is it, can they reflect on what they're doing, or is it occurring because of automaticity? And even physical, opportunity, or social, to be able to carry out any activity you're interested in doing. And in order to do this, to improve on their IP, to find out exactly what is happening with their IPT uptake, they came out with an intervention. One, train to instill knowledge into healthcare workers so that they are capable of doing what is in the guidelines. The second one, to create opportunities, sit with the healthcare workers and participate in what exactly are the bottlenecks in implementing these guidelines and what can be done so that you get shared views from the healthcare workers. This is a very important step because sometimes you may think of an idea on a table on literature, but if the people do not take it up, you don't discuss with the people how it can be implemented, then you're going to fail. So they had to go and sit with the healthcare workers, find out what exactly could fail and what is best for them in order to be able to implement these guidelines and the training they are bringing up. And then they carried out a mentored implementation and feedback. The feedback is to encourage people to be able to motivate them, to encourage them that what you're doing is moving on well, please continue. Or what you're doing is not moving well, please can you have an idea of change? As we know, implementation science, it's a back and forth process whereby you find that people, you don't only bring what you what you've written, you have designed, but you also require from the people. And you continue assessing whether it's happening or not, and what are the best methods to be able to apply this implementation. So, following this training, they came out with these designs, with these aims. They were to evaluate the IPT and TST uptake. 2, to determine healthcare worker fidelity to the guidelines. And 3, to identify the barriers that could be the barriers for IPT and TST uptake, so that they can be solved with this. Now, in terms of the barriers, this is where they had to apply especially the combi model to help to see how people are behaving and whether they have the knowledge, and also where the opportunities to be able to execute the IP guidelines within their clinics. In the design, it was a before and after design. I will discuss more about that. And the setting were 3 primary healthcare facilities that within South Africa, and the study was based on the national guidelines. As I said, these may be old guidelines by the paper, but they were very important at that time. That's 2014. So they really had to see why the guidelines are not put into place, or what's the best way to implement these guidelines into the population. And the study population was healthcare workers, were the ones who were trying to see. So, as I said, the procedures involve training of healthcare clinic staff about what are the guidelines, what do they involve, which population is involved, and how they can be applied within their health setting. In the participatory identification of optimal implementation strategy with each clinic, they send their staff to discuss in each clinic how they can be able to implement this IPT according to their own setting, so that it can increase the uptake. Mentored implementation of chosen strategy. This was to follow up because, as I'm going to discuss, they had to ensure that all the things that they are trying to train are implemented according to the set guidelines. As said, they also look at fidelity of health workers. They had to install a study staff member to assist in IP-related activities and to see that the clinic processes and their documentation. This occurred within 2 months of implementation. The study was before and after. It involved collecting data 3 months before they implemented this study, and these results were to show the baseline actually, what was happening at these clinics, so that we can be able to compare after we have put our implementation in plan. So after the 3 months, then they had to mentor for 2 months. And these 2 months were to ensure that people are taught exactly what the study is all about, what they are supposed to do, and how it will be carried out. And then they had to put their study staff to make sure that everything is following according to what is set within the guidelines. Then after, they let the staff, health workers, carry out their own activities. As I said, study staff were withdrawn after 2 months. And quarterly feedback of the uptake was given to the clinic managers. This is to motivate or to encourage the health workers to continue with what they are doing, or to change if something is not going to the right direction. In the collection, they use routine data, and this is very important because if you bring in your own data collection tools, they may not be sustainable, especially when you do the study. So it was better to use the routine data so that people improve within the setting. And it was, as you do a study staff, and when you do a study staff and also the study ends, the health workers are able to continue from where they have stopped during the study. And as I said, that was extracted 3 months prior to the intervention and 5 months after the completion. Then they had to design a structured questionnaire, which was to identify the barriers. And these were carried out within the 2 months of observation, which was ending because they had to basically, they came at the end of the observation period. That's when they carried out the study, which was basically identifying barriers. And these were really the questionnaire. Much as I didn't have a look at the questionnaire, but they were designed at, as I said, at the COMBI model, which looked at competency, which is capability. Are people competent enough? This is basically more looks at the skills, the people that they have, whether they know that the IPT is there and how it can be applied, side effects of IPT, the population involved. So this is what they do. Then secondly, what are the activities? What motivates these people? Then they will tell you maybe we are overburdened, there are few health workers in the clinics, or maybe anything that could be really demotivating them, or maybe they say the workload is a lot. And then the hurdles rate the clinic flow. If you notice, in terms of IPT, these are people who are coming. They may have also their own different schedules. They may have different timing. They may have their own side effect profile, or even the flow in the clinic. They had to look at this flow, and this was the purpose of actually having the mentored people at the site, to make sure that the flow of the clinic, in terms of patients' movement, data collection, is what the health workers want, and that's what they says to have. In the analysis, they analyze each objective differently in its own, use proportions to assess IPT and TST uptake, and we shall, I think, discuss the results, because there are different populations that they analyze in terms of population, especially in denominator determination. It's always a very difficult situation, especially in program data, which is to get appropriate denominator. And indeed, WHO changed the denominator for analyzing now IPT, because previously I was being confused, but I'm not going into detail with that. But they also discussed that there are different denominators which they use to determine the proportions. In terms of factor associated IPT uptake, they used logistic regression coming from univariate, bivariate, up to multivariate analysis. Assessing fidelity, they used a descriptive analysis, which basically compared people who have, proportion of those who have done according to the guidelines, the way they are set and the way they are trained, against what would have been done to follow it at 100%. And evaluating barriers to implementation, they used frequencies and proportions. The study was ethically approved from all different review boards, as you can see from there. Also from there, and my colleague will take over on results.
Okay, thank you very much. Move on to the next presentation, which should take about 10 to 15 minutes so that we can have enough time to discuss.
Thank you. I'm Grace Kakoola, a trainee under implementation science. Thank you. I'm Grace Kakoola, a trainee in this program, nurse by profession, MPH student. So the results that we are going to discuss had a method result concordance, and they are presented below. Starting with our univariate, first of all, let me mention that clinics, primary care clinics were chosen to do the IPT implementation. So 2 clinics chose to do TST guided IPT implementation, while 1 clinic decided against the use of tuberculin skin testing, and the proportion of clients initiating IPT increased substantially for that clinic which did not choose to do TST, but it was very minimal for the other 2 clinics. Generally, TST uptake did not increase. This is a flowchart of patients that were included in the review. Of 925 patients that were eligible for IPT, only 8% were initiated, and for majority that were not initiated, there was no reason stated. Okay, the 8% doesn't include those that were initiated when they had TB symptoms. So, in summary, the findings show that there was poor IPT uptake, poor health care worker fidelity to the investigation of TB, whereby only 68% of the symptomatic patients were investigated. And then there was poor timing of IPT initiation. For example, the median number of days IPT initiation was delayed to a median 374 days post-AT initiation. For the multivariate analysis, the factors that were significantly associated with IPT initiation were being pregnant, having a recent HIV diagnosis, being on AT, and having a low CD4 count less than 500. The healthcare worker barriers to implementation, this was collected from the survey, the structured interview guide, the structured questionnaire. The barriers that were mentioned the major barriers were time needed to perform a tuberculin skin test, then difficulty in motivating the patients to come back for tuberculin skin test reading, then that there was low IPT awareness among the patients, and then that TB screening, the current TB screening wasn't sufficient to really rule out TB. So for the discussion, they really discussed the major findings, and they mentioned that the uptake of IPT was low, but this was similar to the national estimate of South Africa, which was 10%. And it was, however, it was a bit challenging because it's so much lower than the target, the Stop TB target, which is aiming at 90% of people living with HIV initiating IPT. And also South Africa as a nation had an 80% target according to their national strategic plan to scale up IPT. Then the other thing is that the fact that only 18% of patients were on IPT at the time of file review, remember they reviewed records, but only 8.2% initiated IPT. So this highlights the difficulty in interpretation of register-based estimates for IPT uptake. The other challenge that they discussed is the denominator, because for one clinic, they used all people that were receiving HIV care, yet the guidelines suggest that the denominator, the WHO guidelines suggest that the denominator should be only those newly enrolled in HIV care. But this is challenging, and actually WHO gave an allowance. So that can bring about some confounding. So they also discussed their findings in relation to a study that had been done earlier in 2010, where they found that IPT training was poor among clinic staff, and it was only partly implemented in 71% of the facilities, and only 50% of eligible newly HIV diagnosed patients were initiated on IPT. Then the fact that TST was required, and then the complex stratification by art and TST status in the new guidelines, the new ones being 2014, must have contributed to an even lower IPT uptake observed in this study. So they concluded that IPT implementation under routine primary care conditions is challenging due to the barriers to TB preventive strategies and numerous barriers related to concerns regarding exclusion of active TB, logistical and human resource challenges were cited. So the recommendations included reporting on accurate standardized indicators on cumulative IPT uptake, that it needs to be done to have a successful evaluation of the IPT program. This goes back to the denominator being common. But should they just standardize it to newly enrolled patients or all patients in HIV care? To assure sustainable high uptake of IPT, simplified guidelines, healthcare work and patient sensitization on the benefit of IPT, and political commitment are needed to scale up IPT. Thank you.